I'll do a brief introduction of who I am, and then we'll continue. I'm Dr. Terry McInnes. I'm a physician and president of Bluethorn Healthcare Consulting, and I've had the privilege of being involved with the Patient-Centered Primary Care Collaborative for quite some time, where in the early days I co-chaired the Center for Public Payer Implementation. Now I really work broadly across the country. For example, here in my home state of North Carolina, I'm serving as a consultant to the North Carolina Medical Society on Medicaid ACO reform. And across the other side of the country, I'm working with groups such as the University of Hawaii on the Pharmacist to Pharmacist Innovation Grant, which is aimed at integrating pharmacists into care teams to reduce hospital readmissions, which I believe is very relevant to today's presentation. So this month's theme at the PCPCC has been focused around the topic of medication management. And as you know, the PCPCC has been a longtime supporter and advocate for this critical topic, and is thrilled to have all of you join us today and learn more about some best practices, specifically from the VA. Today's webinar will highlight some of the strategies used at the VA to standardize and enhance the role of clinical pharmacists within the VA's medical home model, and will focus on approaches to measure the clinical impact of these pharmacists on the quality and cost of care for patients receiving team-based care. With that, we're really delighted to have Dr. Anthony Moriali here today to present on the topic. Ed Webb also joins us today to moderate our Q&A session. Before I introduce, though, today's participants, I'd like to go over a few announcements and housekeeping items. First, we're less than 4 weeks away from the Western Regional Conference in Denver, which is on June 9th and 10th. We also, next week, we have the national briefing on May 22nd at 1 p.m. Eastern Time, which will feature Dr. Brian Isitz. He's a professor at the Department of Pharmaceutical Care and Health Systems at the University of Minnesota College of Pharmacy. For those of you that know Brian, he was also recently at CMS at the Innovation Center for a couple of years, really working again on the integration of pharmacists. He understands policy and he understands practice. So you can register for both those events, the Western Regional Conference in 4 weeks, and also Dr. Isitz's presentation at our website, pcpcc.org. For some general housekeeping, please use the webinar software to ask questions or provide comments. To do this, what you do is you submit your questions in writing using the drop-down question box on your screen. During the last 30 minutes after Anthony presents, Ed Webb will open it up for Q&A from the audience. Also, please note that the slides and the recorded presentation will be posted to the PCPCC's website within the next 24 hours. So if you have colleagues that weren't able to attend now or would like to see the slides then, please go to the website after 24 hours. Now it's with great pleasure that I introduce today's participants. So first, our speaker. Dr. Anthony Moriali is Assistant Chief Consultant for Clinical Pharmacy Services and Healthcare Delivery Services Research for the Department of Veteran Affairs. Dr. Moriali is entrusted with organizing, standardizing, and expanding the scope of clinical pharmacy practice throughout the VA. His major responsibilities are focused on identifying and resolving gaps in patient care in which clinical pharmacists have demonstrated positive outcomes, and to establish new roles in complex medication management environments where clinical pharmacists can use their knowledge and training. Dr. Moriali is board certified in pharmacotherapy and has been recognized as a fellow of the American and California Society of Health Systems Pharmacists for his many contributions to the profession. Also, we're delighted today to have Ed Webb, who is also no stranger to the Patient-Centered Primary Care Collaborative. He's the Associate Executive Director and Director of Government and Professional Affairs for the American College of Clinical Pharmacy. In 2010, Dr. Webb was inducted into the Pharmacy Academy of the National Academies of Practice, the nation's leading interprofessional healthcare policy and advocacy organization. Dr. Webb has more than 20 years of National Pharmacy Association executive experience in the areas of policy analysis, advocacy, and professional affairs. What really excites me today about having Anthony present and Ed moderate is you have two individuals here who also have had practical clinical pharmacy practices and experience in working in team-based care. So not only are they helping set policy at the organizational level and at the integrated delivery level, in Anthony's case for the VA, but they know how it's done and should be done. Before I turn it over to Anthony, I'd like to take some time to go over the PCPCC's Comprehensive Medication Management Guide. For those of you that may not be familiar with this guide, we developed a medication management task force at the end of 2008, started 2009, that really began to bring together a broad group of stakeholders within the patient-centered primary care collaborative to define what approach needed to be taken to better coordinate medications within the PCMH environment. And out of that work came this guide that has been very, very successful. A second edition came out in June 2012. And it really provides a framework for any organizations that are looking to integrate a systematic approach, as Anthony's going to mention, into their medical home and ACO efforts. So if you look at Appendix A of that, you'll see guidelines for practice and guidelines for documentation. It's also included in ARC's Innovation Center Quality Toolkit. And both Ed Webb and I were fortunate enough to co-lead, along with Dr. Linda Strand, that effort in bringing that guide forth for our membership. You can find that on the PCPCC website, also at pcpcc.org. So with that, I would like to turn it over to Anthony and then Ed to moderate. Thank you again so much for joining us.
Thank you, Terry, for that introduction, and I do want to reiterate the importance of the comprehensive medication management document that Terry just shared with the group, because to me this was an instrumental document in helping us think about how we wanted to put together a strategy for clinical pharmacy integration in the VA into the medical home, which happened to be starting in 2010. So the document was very timely, it was very comprehensive, and it had a lot of good strategies that you will see that we did take advantage of. So I'd like to just start with an overview of the presentation, so I'm going to quickly run through some of these slides. Others I'll spend a little bit more time on, but as an overview, I'm going to start off with describing the VA's version of the medical home, which the VA has coined as the Patient Aligned Care Team, or PACT. And I'm going to share a little bit about some of the improvements that have already been demonstrated to date as a system, and then I'm going to go into discussion of the approach we took to integrating clinical pharmacists into PACT, with a focus on how do we use those individuals at the type of their license for collaborative practice, chronic disease management, and medication management. And then I'm going to move on to discussion of and the description of the systems that we've created in order to document and capture interventions and activities of the clinical pharmacist. We felt this was something that was critically needed so that we could document how they contribute to the overall care of the patient. And then lastly, I'm going to really go through some new activities we've been doing around pharmacoeconomics and health services research relative to the cost and benefits and implications of a clinical pharmacist in this setting. So first, let's start with the overview of the VA PACT, but before I start that, I want to just mention a little bit about how well the VA has done in general in overall performance in comparison to outside commercial and Medicare, Medicaid. And so on this slide, I just wanted to highlight a few things, and this was really in 2011, 2012. You'll see that the VA really was doing a pretty good job of getting patients with diabetes under their blood pressure control, LDL cholesterol under control, having lower numbers of patients that had hemoglobin A1Cs that were not under control, and really have done an excellent job overall from a quality standpoint if you look at the HEDIS Performance in 2012. But despite that, there was a real feeling that the VA needed to change what it did and needed to become more patient-centered and more focused on team-based care. And so these were some of the core principles of PACT. It was obviously patient-centered and team-based. The team members were all asked to start to work at the top of their license and reanalyze the things they do within a group, and with trying to push down tasks that don't need to be done by physicians into other members of the team. The focus and goals have been to try and improve access and to get same-day access where possible, preventive care focus and population management of high-risk patients, and I'll talk a little bit more about these areas as we get on in the presentation, and to really focus on being evidence-based, and at the end of the day, to be able to provide better care to patients at a lower cost with lower ER visits and lower hospitalizations in the system. So this slide graphic really kind of describes what the medical home looked like in the VA. So you'll see that the patient/caregiver was in the center of the universe, if you will, and around them is what they called a teamlet. And a teamlet was one provider, and that provider was assigned an RN care manager, a clinical associate, and a clerk. And so those core team members took care of those 1,200 patients that were assigned to each physician's panel. And I'll just remind you that 1,200 patients assigned to the panel is because the providers don't spend 40 hours a week necessarily taking care of patients. Many of them have academic and administrative activities that they're involved with. So that's why the patient panel size is at about 1,200. You'll see in the left-hand side the other team members. So there's a whole bunch of other team members, and the reason they're not kind of in the core team membership is they are not assigned on a one-to-one ratio. So if we look at the clinical pharmacists, we have one clinical pharmacist assigned to 3 teamlets. And so they're essentially 3,600 patients that they provide consultation to the team lit on those patients. And then we also have one clinical pharmacist that's assigned to every 5 panels of patients solely to do anticoagulation. And I think there was a broad recognition that centralized anticoagulation done by clinical pharmacists have long ago proven to have superior results, and the VA kind of stayed with that model in terms of activities. So you'll see that there was other members on that team, social workers and dietitians and other people who also provide support to the team. So what changes have occurred since the PACT implementation? Well, patient-provider encounters have increased by 12%. There is more access to providers. Encounters with veterans to the team has increased by nearly 50%. So, and that's due to the broad use of telehealth and telephone and group encounters, because now you got teams taking care of patients, and the patients have more access to team members. There's been a 65% of the veterans now requesting a same-day primary care appointment, get that appointment. So that's a pretty big advancement from where we were at just a few years ago. And 78% of the veterans are able to see their own primary care provider on an appointment date that they desire, not that we desire. So these are really, big advancents. Veteran access to primary care during extended hours has also increased significantly. So these changes are also highlighted by this following slide, which really has 72% of our patients now who are discharged from the hospital are contacted within 2 days to follow up with that patient. Obviously, the goal is 100%, and on a lot of these things, we're not all the way there, but we've made some significant progress. As you know, mental health is a big issue in the VA, and so we have had some significant increases in mental health services. And most importantly, if we look at the endpoints I discussed earlier, we've had a 33% decrease in primary care patient visits to the urgent care and a 12% decrease in acute hospitalizations. And the veterans have been surveyed on a regular basis on this, and they have very positive view and outcomes related to the PACT. So I think the PACT's been pretty successful so far. It's still not evenly applied across all the VAs, and we still have our challenges, but I think we're moving in the right direction. So let's talk a little bit about integration of the clinical pharmacists. We've really focused on trying to get the pharmacists to work at the top of their license. Collaborative practice has been our theme, and as you know, in most, I think now around 46 or 47 states have collaborative practice agreements with clinical pharmacists and healthcare teams. And so we kind of use that same model in that we have pharmacists with a scope of practice, as we call it, which are really the clinical collaborative practice agreements. And this really aligns, as I mentioned, with the comprehensive medication management document we discussed earlier. So one of the things I do want to mention is that the VA is a little bit different in that the VA has federal authority and doesn't necessarily follow state practice laws. So with regard to pharmacists and licenses and qualifications, scope of practice, they establish their own guidance on that. And back in the 1990s, clinical pharmacists were granted medication prescribing and monitoring privileges based on locally defined scopes of practice. And we'll talk a little bit more about that as I go on. We really focus on doing our work autonomously but collaboratively. So we're not independent practitioners. We are collaborative, autonomous practitioners, and that is so when a patient is referred to a pharmacist, they can autonomously manage the disease, do the prescribing, do the laboratory values, but they do that in concert with the primary care provider, and then if a patient gets to goal, they're returned back over to their primary care provider is kind of our general model. So this graphic here kind of gives you a little bit about our vision for our National Clinical Pharmacy Office. So our office was started in 2010, right at the same time that the VA was moving to the medical home model. We never previously had an office that was in charge of clinical pharmacy practice. So we kind of had to create a mission and a vision about what we wanted to do. And the way we saw it is we had a lot of clinical pharmacists who were already working in specialty areas. So you had pharmacists in oncology and infectious disease and nephrology and those areas. And with the expansion of the PACT and the medical home model, we saw that there was going to be a big extension of pharmacists into the primary care arena, and we saw that as a good way to be able to bridge the gap between specialty care and the patient-line care team, and such that clinical pharmacists can often defer patients by handling them in the PACT teams with diseases or complexities that normally might have gone to specialty care. So an example is you might have a difficult-to-treat diabetic, and the primary care provider kind of throws up his hands and says, hey, I'm going to send these guys over to endocrine clinic. And oftentimes we had a pharmacist working in endocrine clinic. But in this case, a lot of times the PACT pharmacist can handle that patient without sending them over to specialty care, thus reducing the number of consults and the overall cost of sending somebody to specialty care. However, sometimes in specialty care is necessary, and they start the patient on a pharmacotherapy, and that might be in something like hepatitis C, where it's somewhat complex. they may start a patient on that and get them stabilized, but then they have another, 5 months or 6 months of therapy. They can hand that person back off to the clinical pharmacist in primary care who can manage the disease for the rest of the way in consultation with the specialty care group. So that's kind of our vision of that. And what kind of role did they play in terms of the pillars of our primary care model? Our main pillars are access, as I mentioned, to improve access. So the pharmacist takes the burden away from the primary care physician by being able to handle medication-related problems. And some of those are side effects. Some of those are titration issues. Some of them are getting patients to understand their medications. And by bringing patients back rapidly, we can get patients to goal without having a physician see the patient all the time. But that, again, is done collaboratively. We also do a lot of care management and practice redesign as part of the overall pillars of the PACT Pharmacist. So I'd like to kind of now describe a little bit about what we found, because in the beginning we really didn't have a good handle on what our pharmacists were doing in the system and how many we even had. So now we have a very strong understanding of our clinical pharmacists, and right now the VA has around a little over 7,000 clinical pharmacists. And of those, nearly 3,000 of them have a scope of practice. So when I say scope of practice, just think prescriptive privileges, disease management, ability to order labs, to order diagnostic tests, whatever is necessary to manage that patient's disease in collaboration with their physician and their team. Of those 3,000 or 2,900 pharmacists, about 76% of them are either residency trained or board certified in pharmacotherapy or in certifications like oncology or infectious disease or those kind of things. The group of pharmacists is pretty much evenly spread through the country. In other words, we don't have any real areas of the country where we don't have clinical pharmacists on teams. However, you'll see in this graphic where they're color-coded that some only have a few clinical pharmacists and other areas have upwards of 60 clinical pharmacists. So we know in some of the major academic centers and metropolitan areas that clinical pharmacists are more entrenched, and they've been widely used for many years, and so those sites tend to have more people doing that. So we've also been tracking the growth of clinical pharmacists over time that have a scope of practice since our office opened in 2010, and you can see this graphic started when we got our first data points in 2011, and we've had about a 46% increase in the number of pharmacists who are now practicing with a scope of practice. And I think this occurred for a number of reasons. One was the primary care medical home, in which they wanted to use pharmacists at the top of their license, so they gave them prescriptive privileges. And I think the medical home spilled over into specialty areas where they started to say, well, why isn't the pharmacist in oncology helping us manage nausea and vomiting and these other areas? So I think we're seeing some spillover from the specialty areas as well. Where do pharmacists practice in the VA? When we look at pharmacist scope of practice by disease state, you can see that the common ones are on the left-hand side, where you have anticoagulation, lipid, diabetes, hypertension. Again, these are no surprise because they're chronic diseases that have a lot of medications involved and difficult to get patients at goal. But I do want to point out the one on the far left-hand side, which is a global scope of practice. So our approach to scope of practice was in the beginning very disease-oriented, and with the advent of PACT and the understanding that pharmacists were truly the medication experts, we wanted to make sure that patients that are seen and the needs of the team were not restricted. So if a pharmacist had the ability to prescribe and manage diabetes and they get referred a patient, but that patient also has hypertension or hyperlipidemia or problems with gout, we didn't want them to say, well, I can't handle that patient because I don't have that scope of practice. So we started promoting a global scope of practice, and you can see the trend since 2011 has been a huge uptake of global scope of practice. The physicians in the medical homes and in specialty care really understood the concept. We worked a lot with our physician colleagues and team colleagues to try and understand how they could best use the pharmacist. And as you can see, the scopes of practice for the other areas has dropped, and that's as a result of the fact that people have switched over to a global scope of practice. And that actually will become important later when I talk a little bit about the outcome slides. So what about the percentage of time? So we got all these people with the scope of practice, but do they use it, and do they use it often? And you can see here that the majority of them work in their practice 75 to 100% of the time, so they are using their clinical scopes of practice. We also worked hard on trying to create a uniform system for scope of practice, and that required a lot of discussion and meetings and education of the field, standardization of policies and those kinds of things. I won't get into it too much, but just rest assured that we've spent a lot of time talking to sites, to pharmacists, to physicians and teams about how to standardize the scope of practice, how to move to a global scope, and what kind of education and training and those things were necessary to do that. We also have spent quite a bit of time on ongoing professional evaluations. So anyone with a scope has to have ongoing quality assurance metrics that make sure that they're caring for the patient well and they're doing the things that they need to do within their scope. So we have a very comprehensive system in the VA of ongoing professional evaluation for clinical pharmacists, so that when they come up for rescoping the following year, that there's plenty of data, and I'm going to show you some of that data, to be able to know that they're doing well with their practices. We've also spent a lot of time on standardized training, because with PACT, as I mentioned, we wanted to move to a global scope of practice, but in the beginning, pharmacists who were assigned to disease management within PACT may not have had experience in some of the areas. So they might have done a residency, been board certified, but over the last 5 years might have been working in a diabetes clinic, and now we're putting them in a clinic where we're expecting them to do osteoporosis and hepatitis C and pain management, et cetera. So we spent some time creating clinical boot camps, and we put our pharmacists through training on chronic disease management. You can see we did phase 1 on the common disease states they would see, and then phase 2 we did a specialty focus but for primary care clinical pharmacists. So we wanted the clinical pharmacists in primary care to feel comfortable when they get a heart failure patient or a mental health patient or an oncology patient. And we're not saying feel comfortable managing all their drugs, but perhaps, for example, in oncology, they might feel comfortable doing some of the anemia work or some of the work around nausea and vomiting, so not to have to send the patient back to specialty care providers. And so we've recorded all these, and we've put these in an area where all our new employees and our trainees, our residents, every year can take these classes. So what's happened since this time? We've had, as I mentioned, a significant number of pharmacists increase in scope of practice, and we've also had a tremendous increase in the number of encounters per FTE, and encounters are the number of patients that pharmacists are seeing and managing. So you can see in FY13, for example, we were over 4 million patients that are being seen and having encounters with clinical pharmacists, and our numbers continue to increase for FY14. So there's been a pretty broad uptake of clinical pharmacists managing these diseases. So now I'd like to move into a little bit about outcome studies. And, you know, everybody kind of is aware of some of the difficulties of doing health services research. You know, it's often difficult at small sites to do a study on how the pharmacist contributes to the care of a patient, and you might have a superstar pharmacist that does it at one place, but you don't necessarily know that you can do that at other places. Sometimes they have very small numbers of patients, they lack control groups, and other methodological issues to be able to really say with confidence that people are getting good outcomes and that it is universally scalable. And as you know from the graph I showed you before, we have pharmacists all over the country, so our question was whether or not pharmacists are achieving similar results everywhere in the country. So we have created a couple different models. One of them I just wanted to mention to you is some work that we did quite a while ago, looking at disease state interventions, drug-drug interactions, managing allergies and those kind of things. And each of those interventions has a value to it. And so we've really tried to really work on trying to make sure that we've assigned a dollar value to it. And this slide just kind of gives you an overview of some of the work we've been doing, but I'm going to skip past this because that one still needs quite a bit of additional work about interventions. And what I'd really like to focus on is our project that we put together in 2012 called the PhARMD project, or Pharmacists Achieve Results with Medications Documentation Project. And what this project was, the goal was to create a national system that was real-time, that could collect all the interventions and outcomes associated with patients referred to a clinical pharmacist. And we focused, of course, on the medical home team as the first place to implement this. So you'll see on the left-hand side in blue, we have a list of the types of documented interventions. So if a pharmacist does an intervention, whether it be manage an allergy or identify a drug-drug interaction, that is documented as an intervention. But also we track every patient that was sent to a pharmacist for diabetes, for hypertension, for heart failure, for bone management, smoking cessation, and the like. So we essentially created a tool that pops up at the end of the visit. So the patients, the pharmacists are all using electronic medical record. At the end of the visit, they click on this tool, and then they just select the radio buttons for what they did on that visit. So in this case, as an example, they would check, I saw a patient for hypertension, and I did a medication intervention, I initiated a medication, and we don't need them to document anything really more than some of these things, because in the background we already know who the patient is that they saw, we already know what prescription they wrote for, we already know all about the patient demographics and the pharmacist demographics for that matter. So what we needed was a tool that captured what they really do when they're seeing a patient. So we started in FY12 with a few sites as a pilot, and then we moved later in the year to, as you can see, 117 tool users. Right now we're nearing 1,000 pharmacists in the field who are using this tool. And so they are documenting right now around 320,000 disease state interventions, and then additional pharmacotherapies might be things like the drug interactions or adjust the dose or those things. So they're not referred for disease management, but they're referred because the patient has some other problem. So you can see we're, you know, somewhere in the range of 600,000 interventions a year. So we're getting quite a bit of data on what pharmacists are doing. So I want to move into talking a little bit about how we're modeling that cost-benefit and the interventions. And the way we're doing that is through the use of the PhARMD data, our central data warehouse where we can extract all the patient demographics and pharmacist activities or what they prescribe and those kind of things. and then I'm marrying that with a tool called Archimedes. And some of you may be familiar with Archimedes, but this is a outcomes modeling tool that's been well validated in the literature and well substantiated, created by Kaiser Permanente, but now is a separate company. And it has very strong correlations of outcomes with surrogate markers. So, for example, hemoglobin A1C, systolic, diastolic blood pressures, LDL. What they did when their validation studies in Kaiser was to be able to look at all of the outcomes, and let's say LDL cholesterol was reduced in a cohort of patients from 140 to 100, and then they would predict the reductions in MIs and in strokes that would occur, and they followed those patients for 5 years, and lo and behold, their modeling was pretty accurate about the percentage of reduction in strokes and MIs. So we've taken this tool and started to apply this to our PhARMD data because we have that data. So I'll just describe quickly, this is kind of our analysis that I'm going to show you right now in the next slides, and that is our PhARMD data run in April 2014. And I will just mention that this is all kind of experimental in terms of us trying to fine-tune our processes. And this represents, what I'm showing you here is going to represent the outcomes as documented by the pharmacist in the PhARMD tool. And we're going to look at specific patients that were referred for a specific disorder. So if the provider sent the patient for diabetes management or lipid management or hypertensive management, then we track that patient for 6 months from the time they saw the pharmacist through the pharmacist visits to the time the pharmacist referred them back to their provider. Or in some cases they may continue them, but we cut off this data at 6 months. So the first one I want to talk about really is focused on this diabetes referral cohort. And these are people who were referred by their primary provider for diabetes management by the pharmacist. So the biomarkers that we tracked in this are hemoglobin A1C, LDL, and we also track systolic and diastolic blood pressure, but we don't have all that data put together here, so I'm not going to show you that data, but the preliminary data does look as if the pharmacists in most cases, when they were referred a diabetic patient, they didn't just manage their hemoglobin A1C in line with our global scope of practice. They managed other problems with the patients, including cholesterol and blood pressure. But you can see here's our baseline and 6-month data. So we had an absolute change of 1.1 on hemoglobin A1C and 11.29 on the LDL, even though they were primarily referred for diabetes. The lipid cohort, on the other hand, had a bigger drop because they were referred primarily for lipid management. We are able to actually use Archimedes with our specific patient demographics because Archimedes is a model based on NHANES data. It may or may not be accurate for our data population. So we're able to extract all the demographics, all the comorbidities, all the drugs, everything for our patient demographic and plug it into the Archimedes model. And you'll see here the reason is, we have, for example, 95.9% males in this cohort of pharmacist diabetes patients. So that's not consistent with the normal population, and may not either be the age. As you can see, they're more geriatric. The BMIs are high. So this is our particular cohort, and we could run our outcomes data based on the NHANES data to reflect more the general population, or we could use our cohort. So what I'm going to show you here is the data from our cohort. So what Archimedes does is it allows us to put in that reduction in hemoglobin A1C or LDL cholesterol, and it gives you a NNT, or number needed to treat. So those of you who are familiar with that, essentially that tells you the number of patients that you need to have that 1% reduction in cholesterol, or in the HBP, hemoglobin A1C, or the percentage of reduction in LDL cholesterol, and then it gives you a number that you would have need to achieve that in to prevent one event. So in this particular case, If you look at control, it's do nothing. If you look at the trial arm, those are the people referred to the pharmacist. So if you look under MI, you will see that we had to get 32 people to those surrogate markers in order to prevent one myocardial infarction. And the 95% confidence interval on that was 29 to 36. So it's pretty tight confidence interval. So we're pretty confident in these numbers that this would be how many patients you would have to intervene on to be able to do that. And you can see that the numbers vary between CHD death, CHF, heart failure, foot amputations, and foot ulcers. But it is a very good predictive model of being able to say for every 35 patients you reduce their hemoglobin A1C by 1%, you will reduce foot amputations by that amount. So using that part of the model, what it also does is give you some nice graphs. So I'm just going to quickly run through a few of these graphs just to give you an example of what we believe is being accomplished in the system. So in this case, we're looking at myocardial infarction, and we're looking at absolute risk reduction. And so you can see that within 2 years, there's a nice divergence of the curve, and that's, again, not a big surprise if you lower people's LDL cholesterol. We know that divergence of the curve occurs relatively early in myocardial infarction. And at 5 years, you have about, or at 10 years, you have about a 5% risk of myocardial infarction reduction. And it also allows you to graph relative risk reduction. Some people like to look at relative risk reduction over time instead of absolute risk reduction. And you can see here that we can maintain about a 30% relative risk reduction for myocardial infarction. We're also looking at foot amputations, and again, for absolute risk reductions, pretty significant. And foot amputations, ironically, are probably some of the most expensive things we can prevent in terms of our overall cost, because patients, not only is it expensive to go through the pre-treatment, the treatment, the amputation, but then the rehabilitation. And so you can see that there's some pretty significant reduction in foot amputations. And this is shown again in relative risk reduction for those of you who like that, 40% relative risk reduction over 2 to 20 years, and it stays pretty consistent over time. Foot ulceration, the same way. I'm just showing you, in this case, the relative risk reduction, again, around 40% for foot ulcers. And then lastly, kind of going into heart failure, there's a 7% absolute risk reduction at 10 years, so pretty significant. And again, you can see the reductions occur very early on with regard to preventing heart failure. So what do we do with that data? So, you know, once we have a treatment cohort, we have a disease that we've identified, we have a clinical outcome and an NNT, we can try and calculate the cost-benefit ratios of using pharmacists to do these activities. And so what we do is basically try to figure out how many visits did it take the pharmacist to get that patient to goal, what is the NNT, what is the cost of a pharmacist's salary, we have all that data, what is the estimated cost of an event, and in this case I'm just using references out of the literature to show you for example purposes, is that for myocardial infarction, you have a return on investment of $5.50 for every dollar that you spend on a clinical pharmacist getting this patient to goal. So the effects of this are across both MI, CHF, foot amputations, foot ulcer, and of course CHD death. You don't do a cost-benefit ratio because you know, it's obviously less expensive for the patient to die, but it's obviously something that we try to prevent from the ethical and responsibility standpoint. So you can see the cost benefits are pretty robust, but what I do want to also point out is that these are not cost benefits that are in a silo. So if you think about those cost benefits that were on that last table, they are all occurring as a result of getting a patient under better control. So you don't just get the benefit of MI reduction, you get the benefit of MI reduction, the benefit of foot amputations, foot ulcerations. All of those things are additional benefits. So if you aggregate the cost-benefit analysis of this, you will see what I have shown you on this table, which is we use the maximum NNT, the maximum visit cost, and we use the myocardial infarction, CHF costs, etc. And your total cost benefit of seeing this patient and getting their disease under control is $28 for every dollar. So what we're trying to look at now is, and as I described to you, this is pretty preliminary, is really looking at different scenarios. So even if we doubled or tripled the cost of the interventions for the pharmacist, we're still talking about $9 for every dollar invested. And I think what this does is it magnifies the importance of the pharmacist having a global scope of practice, because the benefits of those visits don't just occur relative to diabetes control, but occurs relative to hypertension control, to lipid control, and whatever else they happen to intervene on during that time. So we're looking for more sophisticated models in terms of doing our cost-benefit analysis, but we think we're on the right track for being able to show those outcomes. And this is just an example of what you would do with sensitivity analysis. One of the issues that was raised is overlap of comorbidities, and I think I've figured out a way to take that into account, but we haven't worked up that information yet. But if, for example, you say that you can't really take the credit for each one of those outcomes because there's overlap. So, for example, some patients who develop foot ulcers will develop foot amputations, and so there is potentially overlap between MI and CHF and those things. So in this case, I just did kind of a quick sensitivity analysis saying, what if the disease is overlapped by 50%? How would that affect your cost-benefit ratio? And you could still see that it's, even if the diseases predicted each other by 50%, which we think is very high, we had a 14-to-1 cost-benefit ratio. So our additional endeavors as we're moving forward, now that we have all of this wonderful data pouring in and hundreds of thousands of data points coming in a month, we're really starting to expand. We now have over 1,000 users, so we're starting to get more and more patients. We're really looking at patient variability and how that is affected by demographics and comorbidities. We really want to focus on the outcome variabilities by the medications used, by the training and background of the pharmacist, to identify strong practices. So we should be able to, for example, see if some pharmacists in some areas are getting better outcomes than others, and look at, what kind of medications are they using? Do they have different training? Are they doing different practices that allowed them to achieve better results? And then we are in the process of doing patient complexity adjustments based on a number of complexity indexes, and we are matching control groups of usual care in order to look at outcomes achieved in a usual care model compared to, a non-treated model, which is what I was showing you. So in conclusion, I think we can say that the VA's PACT model has made some significant progress over the past years in terms of improving care. We really have taken the PCC documents on chronic disease management and really tried to apply those to our clinical pharmacists, and with the creation, with the practices that we've created, as well as the application of a data collection and analytical tools, we've really been able to start to recognize the contributions and benefits of clinical pharmacists to the health outcomes that are being achieved. And clearly the outcomes are somewhat universally being achieved all over the country. We do have some variation, and we're going to be digging into that variation more as time goes on, but we do know that it's clearly reproducible, that pharmacists can get these kind of results all throughout the country on all different teams, and that the cost-benefit ratios of doing that are quite impressive to the healthcare system. So with that, I will leave you with my contact information, and we'll turn the program over to Ed for any of the Q&A.
Thanks, Dr. Morale. Ed Webb here with the PCPCC seminar work. Do want to open it up for questions. We've had several come in already. A couple of kind of operational technical questions, just to remind folks that a couple of questions came up about whether the slides and presentation would be available, and they will be available on the PCPCC website probably in 24 hours or so. Also, a question came up about, is it pcpcc.net or pcpcc.org? It is now pcpcc.org. It's been migrated to that, but either domain name will work to get you where you need to go, but it is now officially pcpcc.org. One of the first questions that has come in relates to, Anthony, to the number of pharmacists involved. The number of 7,050 was mentioned. The question came in as to what proportion of that pharmacist population are residents versus clinical practitioners. Is there a distribution of folks involved in this that crosses both the practitioner level and the resident trainee level?
Yeah, thank you. That's a good question. We do not use our residents as with the scope of practice, and they are not counted in the 7,050 pharmacists. We do have about 550 residents in the VA system, and we have a significant portion of those that are PGY2, and of course most of them are licensed, but it's our policy that as trainees, the vast majority of those people do not have scopes of practice nor prescriptive privileges, and so the numbers that I showed you there do not reflect any residents.
Okay, thanks for that. The conversation around the issue of patient engagement and helping to set their own treatment goals and blood pressure goals, do the clinical pharmacists in the system use, what kind of tools, if any, do they use to assess patient health literacy? Are the pharmacists doing some of that assessment, or is that done by the team? How do you get at that issue and fully engaging the patients in some of their own care decisions?
Yeah, and that's kind of a multi-pronged question, but I will tell you that one of the focus and the reasons that we did clinical boot camps to train our pharmacists again, or to retrain them in many of the cases, is we really wanted them to care for patients the VA way, if you will. The VA has a lot of national treatment guidelines in terms of diabetes and hypertension and those things, and we are very focused on making sure our guidelines are specifically done for our patient population, and there has been a lot of work done on patient engagement, and this is a major focus of all of our guidelines, is that the goals that are established for a patient, whether it's hemoglobin A1C or hypertension or the like, need to be modified for the individual patient. And so if you saw, I just briefly put the hypertension slide up there in terms of the PhARMD tool, you will note that the pharmacist could select various different goals for the patient. So we don't, say that everybody has to be over 120, over 80. And they work with the patient one-on-one to establish what their goal is. And then we measure over time achievement of the goal that was set for the patient in the initial visits with the patient. And then the VA has done a lot of work on health literacy and teamwork, and we do a lot of meetings, group meetings with patients, and those are multidisciplinary. We do have a lot of nurses and other healthcare team members that have been trained in both health literacy and on working with the patients to set patient goals. We do have, I know, I'm part of a group that has been working on some virtual training that we're going to be doing using cases and actors and all of that stuff that we're just about to roll out probably within the next few months doing just that, about how to talk to your patient about patient individual goals and how to work with them in a way that is non-threatening, is educational, and understands that the patient understands their risks and the rewards of possible therapy. So it's a great question. There's a lot of work being done in this area, and I anticipate that as the teams get more experience and more fully functional, and the patients really start to understand what team-based care and patient-centered care is, that we're starting to get a lot more buy-in where the patient says, oh, you mean I have a choice about what I do and how I treat, and what are important priorities for me as a patient.
Terrific. Thanks for that one. Just a reminder to participants to type in your questions on the dialog box that is available on the right-hand side of your screen. Anthony, you described, you showed some of the screens related to the intervention documentation tool that you developed specific to the clinical pharmacist interventions. Is that documentation tool an integral part of the electronic medical record and linked to the patient's other charts, or is it a standalone tool?
Yeah, another great question. No, that we worked hard to really make sure that any tool that we developed was an integrated part of the medical record. It uses a reminder dialogue technology that we use in other parts of our electronic medical record. And in fact, when a pharmacist selects some of those radio buttons, and let's say they saw a hypertension patient, they set a goal, they changed their therapy, all of that stuff, when they click on those little boxes, actually writes a chart note for them, and then they can edit that chart note. They can take stuff out, they can leave stuff in, whatever they want. But it also does their coding for their visit, so that they don't have to do the coding because that's part of the process. So we try to make it as seamless as possible. And then that data, every radio box that they click automatically rolls up into the National Data Warehouse, which is extracted by our office and put back into reports and provided back to the field so that they know what their individual pharmacists are doing at their individual stations.
Great. Thanks for that. The questions come in about whether the clinical pharmacists are integrating new lipid and hypertension guidelines into their current treatment and management approaches. I presume they are, but that question has come in.
Yes, they are, of course, and that's a continuous educational process. So as part of our boot camps that we put out, we ask people to look at the videos, to take the tests and do the things, but then we also have ongoing seminars when there's changes in practice, and we go back and we edit the boot camps as well so that the new people coming in will see the new guidelines. So with regard to the new lipid guidelines, we're in the process of rolling that back out to people and giving people direction. We also rely on our National Medical Advisory Panel to make interpretations of those, so we got to work in concert with our physician leaders. And when they decide, okay, these new guidelines may have come out from ADA or from other people, they have to really look at it and say, are we really going to adopt those or not, first of all, so we don't automatically adopt them because we look at our own evidence for that. But if they decide that we are going to adapt some of that process, so for example, with the lipid agents, moderate dose lipids, and rather than tracking exact reductions in LDL cholesterol, is being integrated into the system, and they are rolling that out as part of the re-education process for all of our pharmacists.
Okay, thank you. One questioner asked, has the Archimedes model been done with other or utilized with other providers on the care team, and if so, how does the pharmacist compare?
No, we have not. So the implementation of the tool, it has been a phased implementation across the country, just focused on clinical pharmacists. We actually only are really using it in PACT right now, and we have created several different models, an antimicrobial stewardship model, inpatient model, some specialty models in hepatitis C and other areas that we are planning to roll out later this year and into next year. And our focus primarily in our office is on developing tools for clinical pharmacy practice, but we do have the ability to extract case-controlled cohorts out of the electronic medical record, and that's what I was talking about at the end about our future goals here, is to be able to match usual care patients to those people who are referred to a clinical pharmacist.
Okay, the next question deals with another question around team-based care. Pharmacists obviously don't work in a vacuum. How do you account for the contribution of the other members of the team to some of the outcomes that you described?
Yeah, it's a good question, and it's something that we're extracting data on to make sure that if a patient is referred for diabetes, for example, by the pharmacist, that other folks are not, messing around with their medications. But it's always difficult to know if a patient got motivated by a dietitian or by an exercise person or changed their lifestyle, and that contributed to the care of that patient. And so that's why we believe that if we can create a usual care cohort, that some of that kind of goes out in the wash, because you have patients that are also going to have that types of interventions by other people in the usual care model as well. So right now it's difficult to account for that, but we can say that when a pharmacist is referred a patient by their primary care provider for a specific thing like lipids or diabetes or hypertension or any of the diseases they manage that I showed you on that, it's very rare that the physician will continue to make any adjustments on those medications, because they know that that pharmacist is managing that patient. And so although there may be contributions from other people in terms of education or lifestyle type of things, or even social workers having to do with homelessness, which could have a big contribution, the clinical end of it in terms of drug management, drug titration, generally is not done by the providers.
Right. Somewhat related to that then is a question about, are there concerns in the system that the role of the primary care provider and the pharmacist somehow become blurred? You've sort of addressed that with the last answer, but are there concerns in that regard, or is the work sufficiently distinct to not have that be a problem?
Yeah, I believe that in the beginning, of course, when we launched the medical home, there was always apprehension from various team members about what will their role be. And, I think there's recognition that there's so much work to do with these patients that, even with full complements of teams, you can't get to everything, and there's still gaps in care. And I do believe that the physician groups in general have embraced this, and that's obvious by the growth of the number of people that we've had. But they also have been very positive about the feedback. And as I mentioned, we have no intention of being licensed independent practitioners. We're not diagnosticians. We are people that are there to support the disease management for that team. And the physicians really are not in general anxious about that issue, especially anymore. And I think they understand what collaborative care is about. They understand that the pharmacist probably knows more about a lot of the drugs than they do, or has more time to help them manage that, more expertise. And it really helps them get their patients to goal and meet various performance metrics and quality metrics. So I think it's been very well received by the physicians in the group, especially once they get used to working in that type of environment with the pharmacist.
Great, thanks. A questioner asks, now that you have some preliminary experience with your measurement parameters for in all the ways that you presented them. What are you considering tweaking at all in terms of measuring the pharmacist's work and performance?
Well, I think I wake up in the middle of the night every night and think about something I could tweak with regard to the Archimedes and some of the things that we want to do. And so, I was, some thoughts are not only to have a control group cohort on that, but also really to try and figure out a better modeling method to look for overlapping disease contributions. And one of the ways I thought about the other day that I told you I haven't quite executed yet, but is to take, for example, diabetes pharmacists. They have interventions that manage their their hemoglobin A1C. They have interventions that match their LDL. They have interventions that manage their hypertension. And all of those come out in Archimedes as a single result, right, that the patient had X amount reduction in risk for heart attacks, for stroke, for the things. And so what we're going to try and do is take out of that same cohort each of the items separately and then put them in together and then see what the differences are in the NNTs with the various consequences, clinical consequences. And it would be able to then figure out what was the contribution of the LDL reduction or the hypertension reduction to the reduction in MI versus hemoglobin A1C. So I think we have a methodology to do it, but it's a little bit complicated to create the cohorts and then be able to separate out the data. But that is one area we really want to focus on. The other thing is really starting to nail down the pharmacist time. So right now, pharmacists have time visits that we know that they saw the patient, let's say 4 times over 6 months and got the patient dose adjusted. What we don't know, well, we actually know it, but what's not in the model right now is the amount of time of that visit. So we're making the assumption that all those visits were 30 minutes long, but we know that some visits were probably 60 minutes and some minutes might have been 15. Some visits might have been 15 minutes. So we really need to fine-tune the amount of time the pharmacist spent, because that changes the dollar value for the pharmacist's time. And then lastly, I would like to take a look at adding in the cost of laboratory values and the cost of the medications that are used to control the disease, although we do believe that if you took a usual care cohort that was also aggressively being treated, they would have similar costs, but our people will probably be a higher medication cost because they are either increasing doses or adding on subsequent drugs, and so we need to factor that a little bit into the model. And then for personal reasons, I think for our group, we need to get more specific VA costs, and we have databases and systems to get the VA costs, but what I showed you there was, more public data about public cost of MIs and things like that.
Right. Well, that's 2 interesting points there. There was another question here related to how much time do the pharmacist visits entail. So you've kind of addressed that, and there is evidence from other sectors of care delivery and other models of care delivery outside the VA that this more robust approach to managing the pharmacotherapy actually does frequently identify problems related to insufficiently robust drug therapy and the need to actually have the therapy be more aggressive. So that's consistent. And
I think I would also add on to that is that we also have recognized that there's a significant amount of over-treatment as well, and de-escalation of therapy is becoming more and more important, especially in a geriatric population. And as we go towards working closer with the patient about what their goals are and what the reductions are, we're recognizing that, we're not going to be pushing diabetic patients that are 80 years old down to hemoglobin A1Cs of 7 because, they get hypoglycemia, they fall, they break hips, same thing with hypertension. And so, we think there's a significant amount of de-escalation of drug therapy that needs to be done. And not only do you save the money on not treating people, but not over-treating people, but you avoid the side effects. So this is an area we've been focused on with regard to pain management, with regard to PTSD treatment and mental health. And so we're moving a lot of initiatives towards a safety factor as well.
Right. Well, and that really is at the heart and soul of patient-centered care. If it's about what's best for the patient in so many respects. One question about the slide that referenced the specialist pharmacist practice. The question came up about how do the clinical pharmacist specialist and the clinical nurse specialist work together? How does that all work?
So in the system, and I'm not sure exactly what they're talking about in terms of the clinical nurse specialist. So in some cases, like I'll take hepatitis, for example, we have a lot of hepatitis clinics in the VA. Hepatitis is a very common thing in our veterans. And in those clinics, you might have a hepatologist or a GI physician. You may have a clinical pharmacist who helps manage the patient pharmacotherapy and try and achieve the SVRs through managing their side effects and those things. Oftentimes you'll have NPs, so those nurse practitioners who are providers in the clinic as well, while the gastroenterologist or the other people are out there, scoping patients and doing biopsies and things like that. The nurse practitioner and the clinical pharmacist work closely together on diagnostics and management of that patient. And then most of those teams in specialty care do have nurses that work in the clinics, and the nurses do a variety of different roles depending on the facility and what they're assigned, and they may have clerks that check patients in and do blood pressures and those kind of things, but they may not, and the nurse may play some of that role. Nurses often work on education, especially if they're like in a diabetes clinic, an endocrine clinic. We get a lot of certified nurse practitioners, certified nurses in diabetes that might help patients with patient education, with adherence, and those things. So I think it varies by the specialty clinic and the area of practice.
Well, there were several semi-related questions around billing and payment issues. Obviously, the VA is a relatively unique situation budgetarily and otherwise, but there are obviously questions about the applicability of billing and payment approaches to the larger environment, and also questions about, there was a question I'm trusting from a physician on the call who's asking, how does an independent private practice team up with a pharmacist both financially and contract-wise? So maybe a little thought about how coding and billing clearly are different in the VA system than they would be in the private sector.
Well, ironically, they're not a whole lot different, and in fact, many of our veterans have insurance, and we do bill insurance companies for MTM services, and we do generate money through these processes. So our coding processes, ICD-9s and all that other stuff is the same. We have patients who might have significant limitations to their coverage benefits, and so they have either high copays or they use their insurance companies, and we bill them. So we are getting more and more into that billing process, and we have work groups that have been focused on that, and we are generating some significant amount of money in billing for the services. The other part of the question was in terms of on the outside, and I'm very familiar with some of the other models that people are using, especially under the accountable care ACO structure, because that really forces the let's say a medical group who's taking on a patient and going to be responsible for all of their care. It really behooves them to network and contract with a clinical pharmacist. Most of the contracts I've seen are they just pay the pharmacist outright for the number of patients that they manage, and perhaps based on the quality of the outcomes that they achieve, and yet the patient is billed essentially under the ACO, so the medical group gets the funds and then uses part of that funds to hire the pharmacist or to pay the pharmacist as an independent contractor to help manage their patients and get them to goal, because I think they recognize that their time is more expensive than what they're paying the pharmacist, and if they can get higher goals under ACO, if they can achieve higher quality levels, they get paid more money. They get a bigger portion of the money. So I am aware of models that have already been successfully integrated in that way, and I think that's going to be the wave of the future with clinical pharmacists. I just will mention on a side that big companies like Walgreens are getting into this business, and you know, Walgreens is spending a significant amount of money, and I heard at last report somewhere around $30 million. They have just remodeled a bunch of their clinics, their stores, and as many of you know, they have these minute clinic and small clinics with nurse practitioners inside there. They have now shifted the pharmacists out front to do MTM and centralize the distribution processes. And according to those folks, there is no money left in dispensing drugs, and all of the money is in taking care of patients. So what they're really trying to do is set up themselves to partner with medical groups to be able to do disease management in the retail setting in a way that allows that partnership, that collaborative practice to really grow and expand. And my sense is when you get the big players coming in like that, they see that there's money there for it, and they see that there's opportunity. So I would not be surprised if they're starting to roll out kind of canned programs to engage medical groups in how they would hire these pharmacists and their healthcare system, in their case Walgreens or CVS, to help manage those patients.
Okay. Are the clinical disease management boot camp recordings and or the PhARMD tool that you described, are either of those things available? Are they available in the public domain or usable by practice structures outside the VA system?
Well, I'll start off with the PhARMD tool. I would say the answer to that is no, because it's essentially works with our computer system, which I don't think many people have. So outside the VA. Now, having said that, you could obviously review all the information about the tool and recreate it, or there are some proprietary tools that are already available that do similar things. And we didn't use, we piloted some of the proprietary tools, and they're very good, but we wanted something that was seamlessly integrated into our medical record, and so we did a homegrown version of some of the proprietary tools that are out there. With regard to the boot camps, we do have the boot camps now set up on a platform which will allow outside access. Right now that access is somewhat restricted to our federal partners, and that is anybody in a federal organization or an academic institution that has an affiliation agreement with the VA. So if your organization has an affiliation agreement, there is a methodology to get access to watch the boot camps and to be able to download those.
Okay. We have one or two questions left, and just if there are any more, feel free to type them in now. We have about 3 more minutes for questions. Of the 1,200 or so patients that constitute the panel for a team, how and who determines which patients are referred to the pharmacist?
So all of those determinations are local, and we really believe that we can help centrally create structure and create business rules and organization and the like, but it's really up to the teams to decide what they do. And the primary reason is you may have a team who's already doing very well in diabetes or lipid management and is struggling with pain management or mental health or some other disease states. And so we want to make sure that they have the flexibility of moving their pharmacists to best help the team and the patients. And that's another reason we really feel that global scopes of practice are the way to go, because then, if you assign patients in your panel, let's say you have 1,200 patients in your panel, and you say, well, I got these 50 patients that their LDL is not controlled, and you assign those to the pharmacist and you get most of them under control, well, then what? There's going to be a certain percentage that fall out, but after that, you got to move on to other diseases that are not well controlled in your panel. So the ability to look at your panel, look at every disease they have, and see who's not controlled is critical to what assignments and what roles the pharmacists, the nurses, the physicians are going to play in getting that panel to the maximum health that they can.
Right. And finally, I think we have time for one more. The questioner was curious as to whether or not the VA has used clinical pharmacists to help manage behavioral health and psychiatric conditions and medication use. And if so, what data do you have on the evidence of effectiveness in that particular disease category?
Yeah, that's a great question, and we've actually do have a lot of clinical pharmacists with a scope of practice in mental health, and they do manage a lot of patients. We have done some training within PACT, but they primarily work with psychiatry and mental health, more severe patients. We don't have a tool yet developed for measuring the clinical outcomes of pharmacists in mental health, although we do have some pilot studies that have been done in that area, and we are working on that tool. So that's something more to come later. We have really identified all of the people that are out there that are doing those practices and have surveyed them and have put teams together to say, what kind of things are you doing, what should we measure, how do we measure it, those kind of things. So we're making some good progress on it, but I don't have any specific data to be able to report to you other than some really nice outcomes that I saw recently in one of our sites, showing reductions in hospitalizations, improvement in adherence, and improvement in reduction in ER visits with the pharmacist managed group. So, but that's stuff they're working on the publication now, and we're working on the tools to be able to launch similar analysis across the country.
Great. Well, thanks very much. I want to take this opportunity to thank all the participants who were with us on the webinar, and particularly to Dr. Terry McInnes and Dr. Anthony Moriali for leading us through a very important and interesting discussion. I want to remind everyone that same time next week, essentially next Thursday, Dr. Brian Isaacs, the University of Minnesota, as Dr. McInnes mentioned, will be presenting a webinar related to the experience in Minnesota, related to the approach to comprehensive medication management and some of his work with the Centers for Medicare and Medicaid Innovation. Also, just a note for your long-term calendar that the annual meeting of the Patient-Centered Primary Care Collaborative will be occurring in Washington, D.C., November 11 through 13. There will be at least one panel session related to medication management issues as part of that annual meeting, along with a team-based care panel that I think many people on this call will be interested to hear and participate in. So we would encourage you for your long-term calendar to consider coming to D.C. For the annual meeting of the Patient-Centered Collaborative. Again, the information from this webinar will be posted on the pcpcc.org website within the next 24 hours or so. We encourage you to check that out, share it with colleagues, refer colleagues to it, and we look forward to your participation in the next webinar next week. Thanks so much for your time today.